are said to induce weight loss, primarily because they work in the gut, they make you feel full, they reduce your appetite, they make you feel sick, so you're less inclined to eat as much. Sounds great, some patients like them. But there is some restrictions at the moment to their licence applications, and there is a theoretical risk of pancreatitis associated with these drugs, so we always kind of counsel patients that if they develop acute upper abdominal pain, just please let us know about it. And there are some restrictions in terms of renal impairment. And yes, they have no long-term safety data as yet, but they are being used more and more. This is just a wee summary table, really, so you can, I'll give you a minute or two to have a look at it. This just puts them all head to head in terms of what they do, and you can see that they do other things as well in terms of your lipids. Weight's a big thing when you're talking to patients about these kind of things, and the risk of blood glucose is important when you think about self-monitoring. So in essence, they all do something slightly different, and they can all complement one another. This is what the patient tells you they are. We've got metformin, top left, glycoside, top bottom, the wee kind of fleshy coloured one in the middle, your gliptins, pioglitazone to the wee white one, various pens. But the one that the patient likes the most when they feel unwell is bottle of Lucozade in the corner, which can lead to its own challenges. They feel a bit thirsty and a bit tired, they like a wee bit of energy, so they lift their bottle of Lucozade. But that's what they'll tell you. What are you on for your diabetes? I've got that wee white one in the morning, that big bullet-shaped one, and that wee pink thing. Remember and keep insulin up your sleeve though for type 2 diabetes. And you can do that in various ways. In type 2 diabetes we tend to look at once daily basal insulin to try and improve the amount of insulin you've got kicking about in the background in combination with oral treatment. If you need more tight control, you can then split the injection to give it 2 a day with different mixes of insulin in amongst it. And then you can go full whack for your basal bolus regime, which is your background insulin plus short-acting insulin at the time of meals to try and mimic physiological insulin action. And that's really your most successful approach in anybody who requires insulin treatment, but it requires a lot of support and a lot of input. So what treatment strategies are out there in terms of what we've got in the arsenal to use? Well, this is what I was told when I first started doing diabetes. You give them a 3-month trial of diet and lifestyle, and in Lanarkshire we offer them structured patient education, and then they come back in 3 months and we see how they've done, and then if they've not done very well, we'll start adding tablets. Some people say you should start metformin from the very beginning, irrespective of, because of this legacy effect that you get with metformin treatment. Remember your statins for cardiovascular prevention, and forget aspirin in type 2 diabetes for primary prevention. It has been shown in studies that aspirin confers no benefit if you've got type 2 diabetes in terms of your cardiovascular risk. If, however, they go on to develop a heart attack or a stroke with their diabetes, then they get aspirin. So you treat them secondary prevention exactly the same, but for primary prevention you can forget all about aspirin. So that's one less tablet for them to take, which is good. So, step 1, lifestyle intervention plus metformin. Yes, maybe, no. Titrate the dose. If they can't take the metformin because they're running to the toilet all the time, think about a sulfonylurea. Sulfonylureas are said to work quicker than metformin in terms of symptom control. Again, the jury's out on that one as well, but if you want somebody to feel better quite quickly, it's worth considering sulfonylurea over metformin first and then switching them over to metformin when they feel better. That's not unreasonable. If that doesn't work, well, you still go hell for leather with your lifestyle intervention and you add something else. And it doesn't really matter what it is, it just depends on the patient really. If you're worried about hypoglycemia, you might be less inclined to choose glycoside or glimepiride. If you think that if they've got a lot of central obesity and they might have a lot of insulin resistance, you might go for pioglitazone second line in addition to, or you might go for a gliptin, a DPP-4 inhibitor if you're worried about weight gain or you're worried about low blood glucose. So again, you've got some clinical judgment to make. What if that doesn't work? Well, we say in Lanarkshire this is maybe where it starts to get a wee bit more complicated, and you might think about referring to somebody with some expertise in diabetes if you don't have it in-house. So lifestyle intervention remains appropriate, and then you add something else. So you're now on to your third agent for diabetes. And it gets all very complicated, but in essence you've got various combinations you can try. I'm not going to go through all of them because, again, it depends on the individual in front of you as to what you think fits best for them. Remember though, with a non-injectable diabetes treatment, the GLP-1 analogues, when that was first brought out, like every other kind of new treatment for diabetes, oh, that'll be the holy grail, that'll be great, and that'll be the very thing, and that'll stop them going on to insulin. You still need your pancreas to be working, and if it's not, you're going to require insulin. And people with type 2 diabetes, if they live long enough with the condition, may well find that they need insulin, so they shouldn't be used to delay what may well be necessary for them. Step 4, well, they're on insulin by now, so you just get them onto their 4 injections a day and you add in more pills. So you add in pioglitazone, and certainly one of the gliptins is looking for their insulin licence at the minute, so you may well be able to employ that at that stage as well. We all like treatment algorithms. Well, I don't, because I'm not very good at following them, but this is nice. Couldn't fit it onto the one slide. These are freely available online. This is Sine. That fits on one slide. And this is Lanarkshire's, which I like the best because it's got nice colours. So all that's there to demonstrate is there's lots of algorithms for treatment out there, and treatment is very individualised. So you will see a variety of different types of diabetes treatments coming through in patients who are in the hospital for various different reasons. So vascular risk. The best thing anybody can do with diabetes in terms of their vascular risk is stop smoking if they are a smoker. And 25% of people with diabetes still smoke, and it's not changed over the last 2-3 years. You want to get them good control glycemically from a microvascular point of view. Jury's out on whether or not that makes a difference to your cardiovascular risk, but certainly from microvascular complications you want to get that controlled. You want to treat blood pressure aggressively, as you would in anybody with increased cardiovascular risk. Aspirin I've mentioned before. You want to be giving them an ACE inhibitor or an angiotensin receptor blocker if they've got microalbuminuria, so tiny amounts of protein in their urine, and it doesn't matter what their blood pressure is. Statins, if they're over 40, for primary prevention, irrespective of what their cholesterol is. Atorvastatin 80 in secondary prevention, just like the general population. And it's worth still thinking about appropriate treatment if they're intolerant of statins. What other treatment might they need? Antidepressants. There's an increased risk of increased incidence of depression in diabetes, no wonder. And that may require antidepressant therapy. Phosphodiesterase type 5 inhibitors, so that's your Viagras and your Cialis, because they get erectile dysfunction, both in terms of microvascular and macrovascular complications. They might have painful peripheral neuropathy and need drugs like gabapentin, pregabalin, amitriptyline and opiate analgesia. We're seeing diabetes, type 2 diabetes in younger and younger women, and there is a real need to think about contraception for these ladies because a lot of the medications that we use in diabetes are teratogenic. So again, that's something that really needs to be thought about. You might be looking to lose weight, so you might be thinking about, oh, let's start adding that in, Xenical, just to make their diarrhea with their metformin worse. And then there's the smoking cessation aids, nicotine replacement therapy, varenicline, whatever. So this is a typical breakfast for somebody with type 2 diabetes. I'm surprised I've got room for any food, so I don't know why they're not all brilliantly controlled. But you can see that then leads to problems with compliance, concordance, interactions and side effects. And 3 pages of drugs on the interim discharge summary when it comes back to me. So in general, the management of hyperglycemia is difficult, there's no doubt about it. We want to aim for an HbA1c of around 7,